telemetry, as well as decrease the number of radiology tests, as well as the amount of radiation patients are exposed to now for all these diagnostic tests. Our founding partners include community clinics, the County of San Diego, the Hospital Association with all the different hospitals associated in the county, as well as some unique partners, the San Diego City Fire EMS Agency. The first time that we've actually brought the pre-hospital field, or the pre-hospital gateway, what we like to call it, into the healthcare arena and make them a true partner. So our goals and our objectives, first is to build this regional health information infrastructure. Then what we'll do is we'll integrate our health IT care delivery by improving care coordination across the community, as well as improving care coordination across providers. So the whole breadth of the patients are handed off directly, and there's no drop or silo between the different health systems. And again, engaging patients and families to be more proactive in this care. If there is a drop, that they actually pick up the ball and run and say, hey, what about me? Our quality goal is cardiovascular, as mentioned. For the acute care setting, what we're doing is that we're taking pre-hospital EKGs from the field at the home where the paramedics actually obtain the EKGs, putting them into the hands of the cardiologist to make the decision whether they actually need to go to a cath lab for an acute myocardial infarction. We're looking at two metrics. We're actually changing the door-to-balloon time, which is quite known in the healthcare arena, to the EKG to balloon time, whether it's done in the field or at the hospital, as well as reducing the false positive rates. Unintended patient safety as far as dye that patients don't need for cardiac caths that may be false. In the chronic care settings, we're focusing on decreasing 30-day readmissions, as well as in the population health, enhancing both the immunization registry as well as public health surveillance. We believe that the cost efficiencies will reduce not only emergency department visits, but also the 30-day readmissions. But not only that, just allowing the health information to travel from different health system to different health system. We believe this will make a true decrease in the number of radiology tests that are not considered necessary for patients' evaluation. The patients that we feel that are actually going to benefit most from this are military folks here in San Diego, since we have a very large military population that is quite transient, moving from base to base to base, as well as our county medical service patients as well. We're going to build this on what's called the in-hand infrastructure. This is currently in place. This is how the DoD folks hand off medical information to the VA and back and forth. It's also how the CDC is now connecting to these folks. So this is a structured platform that we'll be using. Will be another hub within this, so that the VA folks could also extract patient information they're caring for from our health systems. So we're building this as a hybrid federated model that's compliant both with this INHIN for the federal folks, as well as this INHIN direct compliant. This is a clinical, secured clinical messaging platform that doctors can actually transmit safe patient information from one provider to another. This also allows the beacon itself, the San Diego beacon, to be more flexible, because it allows for communication not only from doctor to doctor, but also from the pre-hospital arena, as well as the public health and immunization. We're obviously working in compliance with all of the state and national standards and on all the committees to make sure that we're up to date and actually moving forward past many of the other health information exchanges that are out there. For the providers, we're providing them as a real-time interface native into their electronic health record, so it's a single sign-on. It's very easy for them to get a nice review moment for the patient's longitudinal health care that's actually touched any other system other than theirs. So within the beacon, this is our structure. The little servers on the inside of the cloud are called edge servers. They're mirrored servers for what the health system is actually sending their clinical information to, so that when a provider actually wants to go and query about a patient, that they actually hit these edge servers and not their true production electronic health records to decrease the efficiencies. So within this, as I mentioned earlier, features within the exchange for the pre-hospital field are not only the electronic patient care records from the pre-hospital field, but also EKGs, images, and also allowing the paramedics in the field to query the HIE itself to say, what do I know about this patient since they can't talk to me? We'll be also optimizing the immunization registry. We'll be importing data from pharmacies and these non-traditional settings, such as these minute clinics that you see at CVS or Rite Aid. Normally those people don't contribute to the immunization registry, where a lot of people go that don't have medical providers to actually get that, so that the whole community is involved. Again, we'll be enhancing syndromic surveillance, always with considering meaningful use for the providers to bring them in and contribute to the whole project. The other component of the Beacon project is the wireless innovations. So we've partnered with several of the private companies to do pilot studies. Again, for the pre-hospital arena for defibrillators, we've been working with Philips, Zoll, Physio-Control to actually get their EKG data and vital sign monitoring directly off the device to the doctor. We've also partnered with Airstrip, which is actually a rather unique device that harnesses all of the raw data directly from the defibrillators, and it can also go and query the different health systems' EKGs for prior information, giving more backup information to the provider to make a better decision. We're focusing on cardiovascular, so for the heart failure patients, we've partnered with Sharp as well as several other private companies to bring in home devices, home wireless devices that can transmit either by Bluetooth or by 802.11, just simple weights, blood pressure, simple things that patients can do at home themselves to get that information to their provider, to see, do I need to come in sooner rather than later? Can I prevent a visit to the emergency room? Or even better yet, can I prevent an admission to the hospital? We're also partnering with several cellular companies for texting, both for medication adherence as well as immunization adherence. All have been very cooperative, very innovative, and always on the leading edge. So for those companies that have medical devices that say, how can I get my device to the doctor, or how can I get my device that's in the patient or on the patient to the doctor, or get the data across? So we see the health information exchange as this unique component to where all of these medical devices can plug into the health information exchange, which can then route that data directly to the provider or the care manager who's actually caring for the patients. So it allows companies to say, hey, this is a new innovative way. I only have to make one plug directly into the health information exchange, and then all the data would pass through. Within the pre-hospital arena, what we've done is we've taken an antiquated base hospital radio nurse, and there are 8 of them in the county itself that don't talk to one another, and actually created a virtual single base hospital where information is passed from radio nurse to radio nurse, from hospital to hospital, physician to physician. As I mentioned previously, Airstrip is one of the pilot studies that we're doing. It actually gets the raw data where the cardiologist can actually thumb through the entire 10-second lead as opposed to a 2-second snapshot or TIFF image for these EKGs, and make a better decision on actually what's wrong with the patient. We see the potential impact for San Diego itself as improving the integration of data across different health records to give the clinician the ability to actually look and view a single view of the patient's data from no matter where they are, so that the healthcare information for the patient actually follows the patient and not the patient having to go retrieve it from different health systems. Also allowing the physician to transmit that data to another doctor or another specialist to say, hey, this patient needs to see you, and here's all the information that has to go with them. It can also alter clinical decision-making to actually change outcomes. And this is one of the metrics that we're actually following is in this clinical decision support component. But having the ability to aggregate information across the community allows for quality improvements, allows for different public health initiatives to be enacted to actually follow how is the San Diego community doing versus how is one hospital doing versus another hospital in a different area. This allows us to not only allow for providers to make meaningful use dollars within the government itself, but also better position for future ACOs that the CMS is pushing forward. So within San Diego, being one of the 17 communities, we feel that we can actually improve patient care by getting more accurate, complete information on that patient to the actual provider who's caring for the patient at that time. Allow for meaningful use criteria to be applied, as well as hints from the federal government are that every entity or ACO that will be created from a health system will have to communicate with some community health information exchange, whether it be a state entity, county entity, or regional entity. And then also allow for the framework for improved community health. As far as private industry, we see that there are opportunities for the medical device industry to plug in directly to the HIE for cost savings, one entity to plug into for not having to go directly to 17 different hospitals. As far as healthcare innovation, allowing for future growth or ideas to be plugged in as to there's only one source to plug into now, not 18 or 200 or 100. As well as technical support and clinical supports by actually creating the middle infrastructure of regional call centers or managed centers where the data goes to. Do the physicians get overwhelmed with too much information? Do we need to create a layer within that where data can be filtered, can be observed, and then only certain entities can actually go back to the provider that require direct action? So with that, I'd like to take any questions if you guys have any. Yes?
How are you partnering with, or are you partnering at all with home health communities, say Sharp or Kaiser?
We're partnering initially with the home health entities that from the hospital systems themselves. So those that have home health systems, such as Sharp, we're partnering directly with Sharp, and Sharp actually controls the home health entities there. Yes.
What kind of challenges that you've encountered in implementing this?
Okay, politics. You want to talk about politics? It's like herding cats. You know, there's only one thing that brings them all together, and that's food. So, having done that, the government allows us to do that because they're funding us. Yeah. It's actually been a good change. You know, if you ask them to pay for it, they're not going to come. But since we have the dollars already, they actually do come. And so also the initiatives from CMS federally make them not only want to play, but have to play. Yes?
There are multiple call centers, I would imagine, with different functions in that San Diego environment. Are you going to have a master call center coordinating all of those and plugging people in? How are you going to do that? And is your CMS pilot project description available through CMS?
It is actually available through ONC, not CMS.
Through?
ONC, there's the Office of National Coordinators. For your other question about the multiple call centers, we're leaving that open for the moment. We don't want to constrict any private industry to say, no, you can't play, or any health system saying, no, you can't play. We're actually asking all of the players within the community that have or touch patients to be a part of the health information exchange in the Beacon project.
Question, when are you anticipating data to look at your goals to see if you're meeting those objectives
Yes.
that you shared with us?
So our pre-hospital, we're actually rolling out at the end of this month. The health information exchange is slated to be finished the 1st of November. And so we will have, at that time, 2 health systems and 5 ambulatory systems, all communicating as well as with the VA and the DoD folks. Yes?
When do you get your medication adherence?
So medication adherence, so can you state that again? Two questions I can answer on that.
Right, so my understanding is you're delivering a text message to the
Yes.
patient, right? So what is the basis for that information, for that text message being delivered? How you know what medication they're on, the frequency of the medication, et cetera, what is that?
So from 2 components. One from the actual EHR record where they do e-prescribing, and the e-prescribing goes through SureScripts. SureScripts actually has the platform where you can get the information back to say that the patient has filled the medication. And at that point, that's when we start the adherence texting. Yes?
I don't know if this is an answerable question, but I'll try and contextualize it in the sense that I intend to ask it. San Diego is a relatively well-dominated medical trade service community by virtue of some of the systems that operate here. Most of them have group practice DNA in their culture to a more or less degree. Sharp, Scripps, large Kaiser presence, even UCSD. Fairly progressive academic medical center with an integrated group practice. Are you finding your inroads here relatively easier than in some of the other Beacon communities? Can you gauge that?
It's hard to gauge when you actually go and ask the other PIs from the other Beacon projects. They're in different stages. You know, I can tell you Cincinnati and Indiana have had a health information exchange for over 10 years, each of them. So they're enhancing what they can do or reaching out to other communities to grab more partners in. For us, building it from scratch, it's actually, I think that we can do a leap over most of the other projects because we do have the cooperation of all the health systems in this, and they can see the big picture of, you know, it's not, it's more for customer care rather than it's my data and not the patient's data. And so that customer care improvement not only improves the health system that's taking care of the patient, but also their home health system if they couldn't make it there to start with.
So follow-up, what are the political obstacles? And
well, it depends on who you ask. If you ask the CIOs, they're very engaged. They're all cooperating. They're all on our board. They're actually driving the project itself. If you ask the COOs, it's the same question you'd ask anyhow. Why would you want a health information exchange when you have the potential to lose dollars or lose customers? So it's those different entities that within each of the different health systems that have to fight among themselves to figure out, is this the way we want to go?
Right.
Yes.
This is a question about sustainability. We just, not too long ago, got over a RIOs, the Regional Health Information Organizations, and very few of them showed that they could sustain themselves in a business model. Is there anything changing here? What do you think about sustainability after that federal funding is diminished or goes away?
So we've done a lot of soul searching for that component because we found that RIOs in the past and health information exchanges have not survived because the dollars aren't there. Having the different health systems actually build the HIE, they do have a vested interest in it and will sustain it themselves, as well as other entities, private companies coming in that need the exchange to actually do business. So we are anticipating actually having a sustainability model.
So you're gonna pass the hat for amongst the providers to contribute, is that what you're saying?
For a component, yes. Not for the whole thing, but for a component, yes. For their own entities. As mentioned with the edge servers, we would anticipate that the health systems pay for their own edge servers because it's their own data, and they have control over that. So that component is actually absorbed by each of the different health systems that have edge servers.
Do you see the payers taking a lead role in maintaining or sustaining the HIEs in the future than the providers? What's your perspective?
That's an interesting question, because if you look at the health information exchange vendors in the country, there's a handful of them, and of the handful, the insurance agencies have already bought half of them up.
Exactly, that's the point.
So it's a tricky contract when these insurance agencies buy up these health information exchanges, because the clients want adamant in black and white writing on the contract that the data is the information exchange's data and not the insurance company's data. So there's a clear delineation so far as not having that, but the insurance companies can see in the future it's worth their time to have these. All right. Well, thank you.